welcome Dr. Jonathan Haas. Jonathan, I'm very happy to talk to you today about your specialty. You are one of the world specialists for CyberKnife for prostate cancer treatment. I visited you a couple of years ago in New York City. I was very impressed by the experience you already had gathered by then. It must be much more now. And I would like initially to ask you to briefly explain to our viewers and listeners what exactly CyberKnife is and how it does relate to more conventional techniques.
So CyberKnife is a radiation platform. This is a brochure. And basically what CyberKnife is it's a regular radiation machine or a linear accelerator that's been miniaturized and placed on a robotic arm. So the advantage of it is it's intelligent. It can actually track the movement of the prostate. It's not a doctor. It doesn't know what the prostate is. So what we often do first is we put 4 little marker seeds called fiducials into the prostate. That's a penny, so you have a frame of reference. They're tiny little, they're smaller than a grain of rice. It's like a much easier version of the biopsy to get them in there. I do probably about 10 to 12 a week. Basically what we do is we numb up the skin of the perineum. That's the flat skin between the testicles and the rear end. We numb up the rectum. And by putting the markers in, CyberKnife has these imagers here that are built into the floor of the machine, which function like eyes. So if you look closely, so this is a model of the prostate. And if you look right there, you see the little black dot right there? That's about the size of one of the markers. So as the prostate moves, which it will, CyberKnife is tracking those marker seeds with an accuracy of less than a millimeter, which is like a piece of hair. So we're radiating less of the bladder, which sits on top of the prostate, less of the rectum, which is where my fingers, which sits behind the prostate, and we're now able to give the radiation faster. Typically, we can give the radiation in 5 days, where historically we did it up into 45 days. So we're able to give a faster, more precise dose of radiation to the cancer and less radiation to the normal surrounding anatomy and get the patients done in 5 days. So it checks pretty much every good box, and we're actually giving a better dose of radiation to the cancer. So historically, with older forms of radiation, we would typically give a dose of about 7,500 to 8,100 centigrade. For the listeners, that doesn't really mean anything. But when we do CyberKnife, when you translate the doses out, we can have that discussion with alpha, beta, things like that. We're giving a dose that's about 15 to 20% higher to the cancer and less radiation to the normal surrounding anatomy. So it's checking a lot of good boxes cancer-wise. We're giving a better dose, we're radiating less normal anatomy, and it's much more convenient for the patient. So they can get back to their lives in a week as opposed to 7 to 9 weeks.
So you do all the fiducials yourself on the patients?
I do most of the fiducials myself, not all. Sometimes the urologists like to do their own, and if I trust the urologist, and many I do, they can do their own fiducials. They just have to be oriented properly. So the prostate, we could talk about that too. So the prostate moves like an airplane. It can move kind of X, Y, Z, and pitch, roll, and yaw. So the CyberKnife, in my opinion, is the only system that compensates for all 6 degrees of motion. Most other compensate for all 3. So we have to put in 3, but you have a minimum of 3. We have to put 4 fiducials in to orient them properly to compensate for all 6 degrees of motion. So I train my urologist, or I talk to my urologist how to orient them properly. So if they can do that, then yes, my urologist also can do the fiducials.
I mean, this is more or less one of the most important things, right? That the fiducials do sit well. And if the fiducials are, I always tell my patients that the fiducials are perfect, because some of the people ask why fiducials, they would like to have a completely non-invasive procedure. And it is a very little invasive thing, but it is so important because only with perfect fiducials you have a perfect treatment. Everything else is pretty much standardized, right? But with the fiducials, you can have a lot of differences. So also in our center, only very selected urologists are allowed to do that because there is no room for any compromise.
Yeah, and done properly. I mean, it takes me about 3 to 4 minutes all in, and we numb the patient up. We don't even put them to sleep. I mean, it's much easier than the biopsy. So like literally, in fact, we were joking about this yesterday in my procedure room. One of my patients goes, I said it's going to be 5 minutes. He goes, I'm going to time you, and I'm like, feel free, and it was like 3.5.
Yeah, I've seen you in New York City doing that. I walked into the room and I looked around and you were already finished when it went very, very fast. I agree. Can you give us a little bit of your personal background as a radiation oncologist and how come you ended up being so much involved with CyberKnife radiosurgery?
Yeah, so my name is John Haas. I'm the chairman of radiation oncology at the Perlmutter Cancer Center at NYU. I've been in this hospital for 29 years. So Alex, you and I becoming the senior citizens of radiation oncology. We used to be the young guys. I chose radiation oncology. I wasn't sure what I wanted to do as far as being a doctor. I initially thought I might be a medical oncologist. I thought I might be, I don't know. And I did a fellowship at the NIH and National Institutes of Health in the United States, and I worked in the lab out of which the Gardasil human papillomavirus came out for cervical cancer. I chose that lab. I'm a basketball player, and the only reason I chose that lab is that they had a regular basketball game on Fridays. But that's the only reason I chose it. But I fell in love with the oncology, so I went back to my medical school, which was Washington University in St. Louis. They had an enormous radiation oncology department called Mallinckrodt. I knew nothing about radiation oncology, but I did know about cancer, so I kind of wandered down to the basement one day. I met a very charismatic radiation oncologist named Perry Grigsby, who's a GYN radiation oncologist. I was super cocky back then. I'm less so now. I said, hey, my name is John Haas. I just did a year of cancer research, and I have no idea what you people do. It's exactly what I said to him. And he laughed. He put his arm around me. He goes, son, why don't you spend some time with me? So I kind of gave up my Christmas vacation that year. I spent a week with Dr. Grigsby. And I fell in love with radiation oncology. And the reason why I fell in love with it is general radiation oncology, you have to be a specialist in all parts of the body. So, for example, radiation oncology is one of the very few disciplines in medicine where you have to know neurosurgery as well as the neurosurgeon, neuroanatomy. You have to know lung pathology or anatomy as well as the thoracic surgeon. You have to know head and neck as well as the head and neck surgeon. And you have to know prostate as well as the urologist. So I kind of like the idea that you became an expert in everything. I like to do procedures. I like to do brachytherapy. I did that initially in my career. That's the surgical implantation of radiation. And I have a short attention span. So all the procedures are very short. So it checked a lot of good boxes. So I became a radiation oncology resident at the University of Pennsylvania. I grew up on Long Island. I came to my hospital here as an attending in 1997, and I never left. As far as prostate cancer and CyberKnife, so we used to be a big prostate brachytherapy practice. That's the radioactive implantation of seeds into the prostate. And then in 2005, about 30 of our urologists decided to buy their own radiation machine. So we saw our prostate volume go from hundreds of patients a year down to essentially single digits. At the same time, we decided to get a CyberKnife initially for what we thought was going to be brain treatment. That's what it was designed for, right? We're both friendly with John Adler. John Adler is the neurosurgeon who invented CyberKnife.
So when was that, like 2010 or?
2005 is when we got our CyberKnife.
Oh,
that was the
same
same
as
year.
we did. Oh, interesting.
This is our 20th year, so we were one of the first ones in the United States to get it. I think we were number 50 worldwide, maybe less than that. So we saw, and at the same time, it's a long story. Let me know if I'm boring you.
Nope.
Jay Friedland and Deb Freeman, who you know, they started doing amifostine for prostate cancer. Amifostine is a mucosal protectant to protect against radiation, initially designed for head and neck cancer. So he was giving a lecture to us on amifostine for head and neck cancer. And it's interesting how things happen. So it was a stormy day in New York, and LaGuardia was backed up. So his flight got delayed back to Florida. So he was stuck with us for an extra hour or two. So he talked about a project that he had using amifostine and using CyberKnife, which he had in Tampa for prostate cancer. we had already ordered the CyberKnife for brain tumors. So he gave us just an off-the-cuff lecture on CyberKnife for prostate cancer.
And your CyberKnife was not equipped.
It was approved. It wasn't anything, but we knew that the biology made sense, right? So I give a whole talk on this. So, you know Laurence Olivier, the actor, right? So he was diagnosed with prostate cancer in the 1960s and treated in the UK. He had a week of radiation, not CyberKnife because it didn't exist. But even then, radiation oncologists knew that the biology of prostate cancer was such that it supported giving larger doses of radiation over a shorter period of time. You know, the alpha beta supported giving that dose. So we now have a system, CyberKnife, that's designed to give larger doses, SBRT doses, precisely to anatomy. So we said, this just makes sense for prostate cancer. So we had a system that we were ordering that could do this. We had a need because we were now losing our patients to the urologists that were taking their cases to a private radiation center. And then we figured out how to market it. You and I were talking about that before we went on air. We developed a very robust marketing campaign directly to the patients, and it exploded for us. You know, we just hit a home run. So so patients just came for this. They saw this technology. They saw that it was sexy. You know, we were just talking about that. You know, the technology was sexy, and the science made sense. So we initially did this on an IRB approved protocol. We wanted to make sure that the institution thought it was safe. And for the listeners, IRB in the United States stands for Institutional Review Board. So you can't just do experimental things on patients. You have to go before a committee of the hospital and say, this is a question that makes sense, that we think is safe for the patient and has the ability to potentially advance care for the entire community. So the hospital agreed. We initially did this on study, so patients knew they were going on study. They had to sign consent, and it worked. And we were one of the first groups in the United States and worldwide to do SBRT for prostate cancer. So we are now in our 20th year. I personally probably treated over 10,000, probably more than that, cases myself.
Wow. It's probably the largest number, isn't it?
It's one of them, and that's without ego. I mean, it's just objectively, we are the largest CyberKnife prostate department in the world for prostate cancer, and we're the largest overall site in the United States. And we now lecture, we teach. I have a course every year on SBRT for prostate cancer that has an international faculty. We have Nick von Haas from the UK regularly. We have, it's been great for our patients, and it's been very great for my department.
I love that you said that and that's what's done in the US much better than in Europe, and also particularly in Germany, that you directly approached the interested parties, the patients, and not the colleagues, or the faculty or whoever. I mean, that is one of my main frustrations. And actually, for the talk I give in 2 hours at Stanford, I'll discuss exactly the same thing. The radiosurgeons need to address their capabilities to the outside world, and not only within their little group, and not only within the physician group, because we know all that. We know that some people don't want to know, and some people ignore you, sure. But you will never be successful with your service if you only talk within your peer group. You need to step out and make clear and what you can achieve for your patients. And we live in good times to do that, right? A couple of years ago, this was much harder, probably when you started. But nowadays, with social media, etc., you have very good possibilities to do that on an easy level. And,
no, I agree. And one of the things that we did when we started, so we've all moved beyond paper charts, right? But when we started this, we used to have paper charts, for the patient, each patient. And on the prescription for the radiation dose, we had 3 lines. One for the radiation oncologist, one for the physicist, and we also had for the surgeon, the urologist, thoracic surgeon, the neurosurgeon. So they had to sign on the prescription to make sure that all interested parties agreed. And it was a hard stop, meaning that if all 3 lines weren't filled out, we didn't treat the patient. because we wanted to make sure that there was multidisciplinary agreement, including on the prescription.
Did they all talk to the colleagues as well? Or?
Yeah, 100%. So I mean, and if I found that if I found that surgeons were reluctant to do this, I just found another surgeon. And it's also good to I mean, you can potentially get side effects with any treatment, right? You've seen neurosurgical side effects. I've seen prostate side effects. We want to make sure that we have a specialist that can co-manage with us just in case there are side effects. So, as a radiation oncologist, I don't pretend that I have advanced expertise in managing CNS side effects or pulmonary side effects or prostate side effects, but we always have a surgeon working with us that can kind of co-manage with us.
Absolutely. So coming back to the focus of radiosurgery for prostate cancer, what are the best candidates after with your vast experience for CyberKnife? And people think it's only for early stage. This seems to switch a little bit, but what's your take here?
Yeah, so we can talk about that. So, to oversimplify it, if you're a candidate for surgery for a prostatectomy, you're a candidate for CyberKnife SBRT. That's to oversimplify it. But to kind of dig into that a little bit, so the ideal candidates are patients that have a Gleason score 7 or below. And so for the listeners, what a Gleason score is. So when patients have a biopsy of their prostate, the pathologist looks under the microscope. They give a number to the cancer cells from 6 to 10, with 10 being the angriest. So a 6 or a 7 is considered low or intermediate risk prostate cancer. Those are the best candidates for CyberKnife alone. And a 7 can be broken up into a 3+4 or a 4+3. What that means, the pathologist gives 2 numbers. The first number is what's called the major histology. What do most of the cancer cells look like? We give that a number from 3 to 5. The second number is the minor histology. What do the rest of the cancer cells look like? And we give that a number from 3 to 5. So a 3+4 means most of the cells are less aggressive and the rest are more aggressive. A 4+3 is the opposite. If you have a 4+3, which is still a candidate for CyberKnife, we'll oftentimes recommend hormones with the radiation. The reason for that is that prostate cancer is a disease that in the face of male hormones, it grows. So when you have a more aggressive prostate cancer, which a 4+3 and higher is, by getting hormones, you kind of temporarily lower the testosterone. You starve the cancer, and that's been shown to have better outcome with all forms of radiation. We actually
how long do people have to take the hormones?
So for Gleason's 4+3 in this country, it's about 6 months. We typically start it before the radiation because the prostate is going to shrink by about 30%, so we'll be radiating a smaller target. Once you have a higher Gleason score, an 8 or above, you can still have SBRT or CyberKnife. We'll oftentimes, at least in our practice, combine that with conventional radiation to treat the pelvic lymph nodes also. So we do combined therapy. We'll often give a 5-week course of radiation to the prostate and the lymph nodes, and then we'll do a CyberKnife boost. So it's a total of 28 treatments for the higher risk patients. So that's our kind of algorithm. And the patients with the higher risk prostate cancer, like a Gleason 8 or 9, are oftentimes on hormones for a slightly longer course, up to 18 months to 2 years. A lot of that's based on European data, by the way.
And but there are other factors as well, right? It's not only the Gleason score. How do you
So other things that look right, we take into account other things. So for example, if patients that have larger prostates, if you have a gland size larger than 60 or 70 grams, sometimes we'll do things to shrink the prostate, either with hormones or with something called prostate artery embolization, where our interventional radiologist will inject a colloid that kind of shrinks the prostate. Although we've published in our experience here on radiating larger glands safely.
What is larger? What would be a limit dose, limit volume? You
60 is considered large, but we actually published. We make fun of. We call it our mega glands paper. We published on glands over 100 cc safely, but that's kind of case by case. We look at something called their IPSS score that looks to see how their urinary symptoms are. If they have a very high IPSS, typically over like 19 or 20, sometimes we'll say those patients may not be great for radiation. They may be a little bit better for surgery because you can get some temporary swelling of the prostate, which makes the urinary symptoms worse. So it's not one size fits all. We individualize it, based on the patient specific.
So volume seems to be a very important factor. I mean,
One of the
people with
factors.
smaller prostates just do better in our experience here, at least. And that's we go up to 80 so far, but it's a difference. Is if somebody has like
Yeah,
25
you can look
cc or 80 cc.
when you have time. We presented this at Astro about 3 or 4 years ago. You know, you just Google my name and large prostates, it should come up.
Okay, interesting. Absolutely. So in Germany here, typically, and I guess it is already different in the US, the number one treatment for prostate cancer is still surgery. Most people are sent for surgery, and most urologists would advise, which is natural because that's their job. Many are not very open to discussions, and
Send me there. I'll talk to them.
Again.
Send me there. I'll talk to them. Give me a half hour.
Okay. How is that perceived in the US, by the way? I mean, in your scenario, what is the number one treatment for prostate low risk or intermediate risk prostate cancer in the US? Can you tell?
In our area, it's probably CyberKnife. But we have our urologist on board. I don't talk patients out of surgery. Yeah, to be honest with you, I think everything's equal. I don't think CyberKnife's better than surgery. I don't think surgery's better than CyberKnife. I think they are exactly equal. And I present that at my consultation as such.
What do you mean by equal? You mean outcomes, in terms of outcome?
Oncology, yeah. If you're for a Gleason 6 to 7 prostate cancer, assuming everything goes properly, which it should, you're looking at about a 90% cure rate, with anything you choose. So then it becomes about side effects, right? If the treatment outcomes are the same, it becomes the patient gets to weigh into this. It's good and bad for the patients. A lot of times patients get frustrated, right? If you're diagnosed, so you're a neurosurgeon by training, someone comes in with a glioblastoma or an astrocytoma, standard of care is surgery, period. Right? They can have radiation afterwards. If someone has leukemia, standard of care is chemotherapy, period. Right? But if you go for prostate cancer, it's one of the few oncologic or one of the few cancer diagnoses that if you go to 5 different doctors, you're going to get 5 different opinions, and we're all correct. So if that's the case, then the patient gets to weigh into the decision. What are their interests? Do they not want to have surgery because they don't want to miss time from work? Or do they mentally want to know that the cancer's outside of the body, taken out, then surgery might be better for them. So we always have, getting back to what I told you with all the doctors have to sign on our prescription, they have to go for a consultation with the urologist before I will treat the patient. I will not let them get on my CyberKnife machine if they have not had a full consultation with a urologic surgeon. Because it's not fair to the patient for them to be pushed for this particular diagnosis, right? I'm being very clear on that because, patient sees you and you're one of the world's most renowned neurosurgeons. Someone has a astrocytoma and they want CyberKnife. That's the wrong treatment, right? Sure. Period. So that's why we have them meet with the specialty surgeon to make sure that they've had the chance to explore other options. Surgery.
And the specialty surgeon is not competing, is not telling the patient, listen, I think you should get operated because CyberKnife is not mature, the data is not out there.
Yeah, that does happen.
That does happen, right?
But I won't send the patient to a urologist. So I become the referrer. We've kind of had a niche. So most radiation oncologists are referred patients. It comes from the surgeon usually. Our practice is a little different because we've been doing this for so long that patients come directly to us. So let's say patient's already had a biopsy. So let's say the patient has a biopsy in the community by a surgeon that is pushing the patient to surgery. Prostate cancer is nice for the patients because they have the luxury of time to do homework, right? Someone comes into the ER with a seizure and has a 5 centimeter or 4 centimeter, astrocytoma or glioblastoma. They're going to be in the operating room table within 48 hours. Someone's diagnosed with a prostate cancer, they can have weeks or months to do their homework. So in New York, patients are pretty savvy, most places, but our patients are very sharp for the most part. They can kind of sense when they're being pushed towards something. So I see lots of patients that come independently after they've had the biopsy. I know most of the urologists in the area. I know who's good and who's not, and who's pushing and who's not. So I always have them see one of our urologists at NYU or NYU affiliate to get a neutral consultation. So we do see it in the community that patients are pushed towards surgery, but they're coming to us anyway for the second opinion, and I'll just get an independent urologist to see them.
I find this particularly difficult for patients in the field of prostate cancer because, as you said, there are multiple options, and they are pretty equal in terms of outcome, and everybody is speaking a little bit for themselves, of course. If they talk to a conventional radiation oncologist, he would suggest that. If they talk to an oncologic surgeon, they would suggest that. If they talk to a CyberKnife, they talk about...
I never do that. And we have, for example, we have a very active holistic surveillance program. So I think probably a third of our patients do not need treatment. And we have a robust, active, holistic surveillance. So we can talk about this. So active surveillance means what? So if you have a Gleason 6, a low-grade cancer, and you have a PSA that's relatively low, those patients probably don't need treatment. So active surveillance just means you watch it. You get a PSA a couple times during a biopsy. We believe in something called active holistic surveillance. Aaron Katz, who's our chairman of urology here, has enlightened me to this over the past 10 years. So with diet change, with lifestyle change, with supplements, a lot of these patients may never need treatment. So if I see a patient with a Gleason 6, PSA 4.1, 2 cores positive, I will push that patient to not be treated for the time being. And they'll see Aaron, Dr. Katz, to talk about active holistic surveillance. In addition, we do something now, you probably do the same, I would think, use genomics, the RNA sequencing of the prostate cancer. I like Decipher. There's another one called Oncotype. They kind of both work similarly. But we send the pathology off for genomic testing, and it gives you a score genetically or genomically that, if you have a low aggressive cancer on genomics, those patients should probably be watched. And, so, at least in our area, we don't push patients. I never push a patient toward radiation ever. I treat lots of them. But we never push them. That's why we have them see the surgeon. If a gentleman wants surgery, then by all means he should have it, because they're equal.
Absolutely. And I do this as a general rule. You giving your experience and also a little bit my experience, after 10 seconds what people believe and what they want to hear and maybe what not. And if you figure that they come to you because only the neighbor said you go there, or they read about it in any magazine, but deep in their heart they want surgery, they say, okay, I have a problem with cancer in my body, I want to get it removed.
And that's a valid reason to have surgery.
Sure, it makes no sense to try to convince them otherwise. And of course, we do the same thing, that we say, okay, you need to see a surgeon, get all the information there. And then if you want to come back, we can talk again. But before you have not a surgical consultation, we would also not treat them. And a radiation oncology consultation. You're a radiation oncologist on your own. We do have radiation oncologists in our team now, but I want to have an external radiation oncologist to have no bias at all. So external radiation oncologist, external surgeon, and then we can talk again.
Yeah, so Larry Solin was one of my mentors at the University of Pennsylvania. He was actually a breast specialist. And I used to do a lot of breast radiation. And he gave me a piece of advice, which it transcends all specialty. He goes, I never talk a patient out of a mastectomy. Meaning if a patient wants a mastectomy, he will never talk that patient out of it, because no good can come from it, right? If a patient wants surgery and you're forcing them to not have surgery, and if everything doesn't go perfect, you're going to have a really bad outcome. So I never...
They will be never happy. For sure.
Correct. And I never talk a patient out of a prostatectomy now. So if a patient wants their prostate out, I will never talk a patient out of it, because that's a perfectly fine treatment.
Absolutely. We agree here 100%. So can you just briefly explain again, how does it compare against standard radiation, which is still a big field in prostate treatment?
Yeah. So oncologic outcomes are the same. It's, if I give 7,500 to 8,100 centigrade with conventional IMRT, intensity modulated radiation, outcomes are the same. I mean, I think the side effects are better when you do SBRT. There's data to show that. There's, so again, I give lots of talks, and I have a slide of a woman going like this. It's our little secret, right? Everything works. That's the secret. Everything works, right? 9 weeks works, prostate brachytherapy works, prostatectomy works, CyberKnife works. It all works, meaning that the outcomes are the same. So then the patient gets to choose. If a patient wants, so I had a patient, who was referred to me. His family member was on staff at the University of Pennsylvania, which is where I trained in Philadelphia. And the family member said, you have to have IMRT. You have to have 9 weeks of radiation. And I tried to tell the patient, I think CyberKnife is good. Patient wanted an IMRT, so I did it. I didn't talk the patient out of IMRT because that's what he wanted. And we can do that, right? I can.
So for which patients do you precisely prescribe IMRT?
So if a patient has a Gleason 8 or higher, right, there's a formula called the Roche formula, named after Mac Roche, who's a legendary radiation oncologist. I won't bore you with it, but just to give you 30 seconds, it's Gleason score -6. It's 2/3 the PSA plus Gleason score -6 times 10%. That's the risk of lymph nodes. So it's an oversimplification, but if the risk of lymph nodes is going to be 20% or higher, thereabouts, or 15%, those patients should probably have their pelvic lymph nodes radiated. So in general, that's like a Gleason 8 or above, or a PSA kind of 20 or above. So those patients get IMRT in our practice to the prostate and lymph nodes, 4,500 centigrade over 25 fractions, so 5 weeks of radiation. And then our practice here is to also do 3 fractions on the CyberKnife, so it's 28. So in my opinion, we're combining the best of both types of radiation. And it's still more convenient to have 28 treatments than it is to have 45, because the standard IMRT is 45 treatments. Some people are now shortening that down to 5.5 weeks, which is good, but we've been doing that for 2 decades.
Sounds interesting and makes sense. So what about local recurrences? We get increasingly demand of local recurrences, and there we come a little bit back to the idea that surgery always is the best idea, at least in the mindset of the urologists, because what people don't tell is that there is above 20% risk of recurrency even after surgery. So the surgeon will tell, okay, no problem, we get your prostate out and you are healed, no more problem. But that's not the truth, unfortunately. And it's very easy to find the data. This is a 1-minute Google search, 20% recurrences all over after a prostate surgery. So we have many patients also with local recurrences. Many of them already had also conventional radiation. And they come back with a 1 centimeter PET positive activity in the prostate bed. What is Dr. Haas recommending?
So let's take a half step back. You're correct. So with any treatment for prostate cancer across all risk factors is about a 20% recurrence rate. So let's do surgery first, right? So this is the prostate. The urologist takes it out. Patients think it can never come back. It still comes back about 20% across all risk groups. Where does it come back? Usually in the prostate bed, where the prostate used to be. So if even 1 cell's left behind, 1 becomes 2, 2 becomes 4, 4 becomes 8, so on. Then you have a recurrence after prostate surgery. That happens, you get one option. You can have regular radiation, right? You can't have CyberKnife because your prostate's in a garbage can somewhere in the pathology lab. And that will work about 80% of the time. That's your one option. If it comes back after CyberKnife or any radiation for that matter, it's difficult but not impossible to do surgery, but it is a more difficult surgery because things scar down. So we have Aaron Cass here, who's our chair of urology. He is the world's expert on cryotherapy. So in his hands, you're freezing the prostate. In his hands, he can cure 2/3 of patients where it comes back after radiation failures. And cryotherapy can be done multiple times. So you actually have more options in the unlikely event that CyberKnife doesn't work than you do in the unlikely event that surgery doesn't work. There is a large newer volume of data supporting giving radiation a second time, doing re-irradiation. I'm going to be honest with you, I've not done it yet. I mean, I probably will very soon. The reason why I personally have not done re-irradiation is because I have Aaron Katz on faculty here. And Aaron made his career on cryoablation salvage of radiation failures. But there, Don Fuller, who's a good friend of both of ours, has published beautifully on re-irradiation for prostate cancer. I'll end up doing it, I predict, in the next year because the data I think is now compelling enough that it's safe to give second courses of radiation. I just haven't done it personally because I'm just lucky to have Aaron Katz here.
It's interesting. I wasn't expecting this answer. We have treated now, I think, 300 prostate recurrences with CyberKnife, and our experience is just excellent. I think it's one of the niche areas where we are particularly good. We play, for this 1 centimeter recurrency, we place a fiducial right there. We do the PET, we do the advanced MRI imaging with diffusion, etc. And then you treat just in one fraction. And I say that not because I say that all the time, but it is, I think it's the ultimate single session radiosurgical indication because you track it. We give something between 20 and 22.
Yeah.
One time, if it's small, we have very, very, very minor side effects. Very minor. It is very fast, very precise. It is a 20 minutes treatment, and with a nice steep gradient of the CyberKnife, you have very little burden, particularly for small volumes. So we are doing a prospective study on that, and hopefully we have soon some more mature data. But I find this very, very interesting, and it works pretty much in all locations. Some of these recurrences are at the bladder wall or at the anastomosis. So these are the areas where people are afraid. But if the volume is small, you don't have to be afraid at all.
No, I'm not afraid to do it. It's just, we just have we have the world specialist.
I don't mean new, I mean general.
Yeah, right? No, I get it. I'm actually looking forward to doing a retreatment. It's just since we have Aaron here, to be fair, I offer the patients, we have the world's expert on salvage cryoablation, which is it's an outpatient procedure. Again, if a patient wants to be, I have no doubt that within the next year, I'll probably do at least a retreatment, probably more, because, I've treated thousands of patients, so I definitely do see my own recurrences. But, again, I just send them to Dr. Katz because he's right next door.
I understand. Maybe we can share our experience at one of your next symposiums on
that'd be neat, 100%.
prostate radiosurgery. I think many people might be interested. And I know the Fuller data, etc., and Italian data, they all go for multiple fractions. I don't think you need 4, 5, 6 fractions for that. One fraction, if the volume is small, one fraction is probably the best thing you can do there.
Yeah, most of the retreatment data is in 5 fractions. They're just tightening the margin to maybe backing off the dose a little bit, and they're making sure that they've come up with safe constraints for bladder and rectum for patients that have had prior radiation. The one area where they've had problems, and this is my discussion with patients that have had prior brachytherapy, have had a higher risk of complications with retreatment. So
we've seen that. The nice thing is the guys with the brachytherapy don't need fiducials anymore because the whole prostate is full of fiducials.
Right, exactly.
But also with small volumes, we also have there pretty good effects.
Yep.
I'm not sure if you've seen this in the recent Red Journal. It was a very interesting paper, I thought, for high-risk prostate, where they did SBRT for the prostate and also for the lymph nodes.
I've started doing that.
I wanted to, do you do that now, or have you done that for a longer time?
I just started doing that on my first patient about 6 months ago. I did it on an older gentleman who was in his 80s with Gleason score 9 prostate cancer that came to me from about 2 hours away that wanted me to treat him. I thought he was the perfect first case to do it on because he was older. He didn't want to come back and forth. I thought 5 fractions would be better than 45 fractions, and I did want to treat his lymph nodes based on the Gleason 9. So we did that. He did great. We did 5 fractions. I gave the standard 725 times 5 to the prostate, and I did 5 times 5 to the pelvic lymph nodes on the CyberKnife.
Yeah, that's what they did. Yeah.
Right. And he did great. So I'm comfortable doing it. It's a little bit of a longer treatment because the field is so much bigger. It probably took us about 45 minutes as opposed to 20, because you have to radiate the entire pelvis. So yeah, I'm comfortable doing it. I will probably start doing that more. So yes, I did see the paper. I have started doing it. I will probably look to do it more.
And they had like, I think, what was the follow-up time? Like 3 or 4 years, and they had almost 100% control in the pelvic area. This
It
was
makes
quite
sense,
impressive.
right? So the dose is the dose 5 times 5. 500 for the listener, sorry, 500 centigrade and 5 fractions, translates out, when you do the math with the regular radiation, to about 4,500 centigrades, the same dose. So it makes sense that they should do as well as the patients that have the standard doses of radiation, and it's more convenient. It goes back to 20 years ago when we started doing the 5 fractions as opposed to 45 for prostate only, so there's no reason why we can't do it, in my opinion, for the pelvis also. And the 5 times 5, so again, I'm speaking to one of the preeminent European oncology specialists, the 5 times 5 has been done for many decades in Europe for rectal cancer.
Right.
And the anatomy is the same. So yeah.
Absolutely. Do people still get proton therapy in the US for prostate cancer? This is kind of dying out here in Europe.
Yeah, I'm not a fan of it. We can talk about that. So I'm a horrible artist. So protons takes advantage of something called the Bragg peak, BRAGG peak, which means that theoretically all the radiation is given over a very narrow area in space. The problem with protons for prostate cancer, if I can do this, is that the prostate moves. So they have to do something that keeps the prostate in that window. What most will do is they will inflate a balloon into the rear end. The balloon pushes the prostate up against the pubic symphysis. That's the hard bone behind the penis. The problem with doing that, though, is you're pushing the rectum into that Bragg peak. So there's good data showing an increased risk of GI side effects with protons for prostate cancer. You can predict that. Protons happen to be fantastic. Let's say, God forbid, you had a child with a spine tumor, like a medulloblastoma. The spine sits in that Bragg peak like a building. So great for children, not quite as good, in my opinion, for prostate. So yes, the proton centers will offer radiation for prostate cancer because there's a lot of it, and they have to pay for a $100 million machine. In my opinion, the side effects are worse with protons for prostate cancer.
I mean, unfortunately, people at the proton centers just don't tell the truth about the beam, right? You explained it well with the Bragg peak, and they say, okay, the beam is coming in front of the prostate and is stopping where the rectum is at the end. But as you nicely described, the thing is moving. So the beam is not coming from ventral for prostate because it's much too dangerous. It's coming from the side.
Right. And,
if it's coming from the side, the whole Bragg peak thing doesn't make sense at the side because laterally there's not much going on.
And at the plenary session of ASTRO this past year in Washington, there was a randomized trial showing no benefit to protons for prostate cancer, right? That was one of the plenary session abstracts.
Yeah, I 100% understand. So what do you tell your patients in terms of comfort and downtime? They get their 5 sessions and they get to work next week, or do they take some time off? What do you do?
They can work through treatment. We always have patients do their first follow-up with us at 3 weeks after.
So early?
The reason we do, it's just a phone follow-up, just to make, the reason we do that, at least in my experience, that the side effects peak about a week to 10 days after the treatment's over. The ones that we'll notice are some urinary frequency and some rectal urgency, feeling like you have to pee, feeling like you have to have a bowel movement. First week out, they peak. Second week, they level off. Third week, they get better rather than worse. So patients can work. They just have to know where the bathrooms are for a couple of weeks.
Do they get any supplements or medication in this time?
As needed. So we don't put the answer.
Not generally.
Yes. So we have I have my own kind of algorithm that we use for so my first intervention is usually just an anti-inflammatory, Motrin, Advil, or Aleve. If that doesn't work, if it's urinary side effects, I'll then go to Flomax, so one of the alpha agents. If that doesn't work, I'll double up on the Flomax. I'll go from 0.4 to 0.8. If that doesn't work, then oftentimes I'll do like a Medrol dose pack. And that probably fixes 98% of the short-term side effects.
Right. And what about sexual function? I know this is so hard to measure, right? But what do you tell people?
Right. I mean, so the impotency rate for CyberKnife is about 25%. With the other forms of radiation, is 40%. But let's dig into that a little bit deeper, right? We're both men, we understand. So prostate cancer is not a disease of 19-year-old university students that can have sex 3 or 4 times a night, right? It's a disease of men as they get into their 50s, their 60s, their 70s, and lose potency anyway. So half that number that I gave you is felt to be attributable to treatment. The other half is felt to be attributable to age. There's medications to help with that, Cialis, Viagra, things like that. I do tell patients that they will notice decreased ejaculate, decreased semen. That's with any treatment for prostate cancer, but that makes sense because the prostate helps make that fluid. But that's the sexual side effects. Those are the numbers.
People here say that you may do this for older patients, but younger patients should not get radiation. The younger patients need surgery. This is still sticking to the mind of people. I
don't agree with that.
That's new. I don't agree, and you don't agree.
Yeah, they're equal. You see, they're plain and simple.
I would rather say the opposite. I mean, if you are young, and we have no patients 45, 48, 50 years old, so 50 years young.
Yeah, I have a whole series on men younger than 50 that we published on.
Oh, well, and same good results, right?
Same. I mean, yeah, it's identical, not better, not worse, equal. And if you look at the PACE study, right? PACE A was released. Yeah. So the PACE studies, again for the listeners, there's 2 studies. Well, there's more now, but PACE A and PACE B were dual randomized trials. PACE B, so patients were randomized. If they could have surgery, to either surgery or SBRT. If they weren't surgical candidates, were randomized to SBRT versus conventional radiation. PACE B's already have longer term outcome. It shows equivalent outcome with better side effects with the SBRT arm. PACE A, which was the surgical arm, was just released in the last year. The side effect profile by Nick von Haas, who's a friend of both of ours. Other than the urinary side effects, other than the rectal side effects, all the other side effects favored SBRT, including the sexual side effects. So it was better, in a phase 3 trial with SBRT, and that was a CyberKnife predominant study.
Yeah, it was significantly better, right? I mean, if you saw the data of PACE A, which was surgery versus SBRT, and I was surprised to see that after 2 years, 50% of the patients still had a pad in their underwear.
That's right.
And I think in the CyberKnife or SBRT group was 4%, which is about the normal rate in this patient group in terms of age. That is a profound difference.
Yeah, there's a neat paper that was published out of Indiana. And what they did is they had a 5-year longitudinal survey sent out for patients in the state of Indiana. Indiana or North Carolina, I forget, I have it. Regardless, showed the same thing. All patients were treated for prostate cancer with all treatments, surgery, regular radiation, SBRT, and active surveillance. And they had the survey given out every year. And at 5 years, the patients that had the highest treatment regret, meaning that they regretted their treatment, were patients that had surgery. Patients had the lowest treatment regret were the active surveillance patients. You can predict that because they did fine. They weren't, they had no side effects. Patients that had the second lowest regret were the patients that had SBRT, and all those patients were CyberKnife.
Yeah, completely understandable. We are starting a trial this year in Germany for 3 fractions. So I think we will go down from 5 to 3. I've read you are doing a study on 2 fractions. That's probably coming from the prostate, from the brachy experience.
So
what's your stand here?
Yeah, so that's been accepted for an oral presentation at Astro this year. So we have treated, I think, about 40 to 50 patients on study. And their outcome, at least with short-term follow-up out to about 2 years, is equal to patients that have had the standard 5 fraction. So we are offering, it's still on study here. We haven't met the full quota for the study. We're getting close. I think the quota is 50. We're in the 40s now. But we will be offering that as a treatment for 2 fraction.
Is that the same indication criteria as for 5, or is that any difference?
Same. And we do a simultaneous integrated boost based on the Decipher score. So we give 12.5 times 2 to the whole prostate, and then we do an intensification to the PIRADS 4 lesion or above, 14 gray times 2.
If you can detect it, of course. I mean, there are cases you cannot really see something in the MRI, or
so
do you always see something?
Right, those patients don't get the SIB, and it's stratified by Decipher score. The only patients that get the boost are patients with high-risk Decipher.
Yeah, we do this for like 7Bs, where we see a clear spot in the MRI, so we give an integrated boost there, and it has a profound effect.
Yeah, makes sense.
It's the PSA is rushing down like crazy, which of course makes a lot of sense. And the nice thing with the CyberKnife again is that you don't have any compromise in terms of toxicity or bowel or urinary problems. You can give much higher internal dose there without compromise on any surrounding structures, and that is kind of fantastic. And I think still people don't know that, and still people do not really take the full capabilities CyberKnife can do here.
Agree.
Any words on long-term success rates of your patients? What can people expect after you have 20 years experience, after 10 years?
Yeah, I mean, with any treatment for prostate cancer, you may have some longer-term side effects. So we quote a 5% risk of rectal bleeding and a 2% risk of bladder bleeding. It's low, but you can see that several years out. That is fixable. Patients may always have some increased urinary frequency or some increased change in their bowels. So if you're the type of person 10:08 every morning, you always have a bowel movement. You may be a little less regular going forward, but also part of that's a function of age. Patients just tend to become less regular with their urine and their bowels over time anyway. Things like BPH, etc. Sexual side effects we talked about. I quoted 25% risk of erectile dysfunction, but again, if you looked at 100 men that are 100 men that are 70 that never had prostate cancer, many of them will have sexual dysfunction anyway, just as a function of age. That's pretty much what I talk about. If you look at second malignancies, right, second cancers, so I tell patients, if you look at 100 men with prostate cancer that do not have radiation, there's a 2% risk of developing a second cancer. Oftentimes it's a bladder cancer because that area is a little bit abnormal in general. Radiation adds 1% to it, so it's low, but they're entitled to know that. That's really about it.
Is CyberKnife generally available all over the US? You said in your area it's the #1 treatment application. How does this play out in the rest of the US?
There's CyberKnives throughout the entire country and the entire world right now. And there's other systems that do SBRT also. I mean, I don't pretend, my course, which we've talked about, it's a platform neutral course, right? I have people that do variant SBRT, Electa SBRT, MR SBRT. Again, the dose is the dose. If you have a good doctor, I have a funny slide, so I'll ask you a question. If you're driving from Berlin to Munich and at 70 miles an hour in a Mercedes or a BMW, same speed, who's going to get there first? They're both going to get there at the same time, right? So
the one with the better driver.
The driver's doing 70, right? Equal speed. So same point. If someone is a good radiation oncologist and they're using a LINAC-based platform or a CyberKnife platform, I think SBRT has really arrived for everyone. I'm biased toward a CyberKnife because in my hands, I think it's the best radiation machine out there for this particular treatment. But if some people like other systems and they're competent doctors, they probably can do a good job. I think CyberKnife's more forgiving because of it was AI before AI became sexy, right? It's been artificial intelligence, robotic tracking from the second it was invented. So, it has sub-millimeter accuracy. I think it's more forgiving for a new doctor trying to do this. And I think the most important person on the team, or as important, is the physicist, right? You have your physicist who I met is fantastic. I have Matt Witten. They're the ones that are really responsible for the safety of the treatment, making sure that the QA and the output and the tracking, is spot on. So if you have a good team, you can probably do SBRT and lots of different things. I'm just biased toward the CyberKnife because that's really the pioneering technology for this particular treatment.
Oh, yeah, absolutely. And I discuss this often with my patients. They they often want to have, and I'm sure you experience the same technologically driven discussions. He has a Varian or he has an Elekta and he has a CyberKnife. What is better? This is the wrong question. Still the human interface is the most important factor.
It's the pilot, right?
Right. The pilot and the co-pilot, as you said.
And the co-pilot.
It's the pilot and the co-pilot. If that's not too negativistic for the physicists, they will believe they are the pilot.
If you remember about 10 years ago, remember in New York, there was the plane that got hit by the birds. Sully, right. The pilot, and he landed on the East River, right?
Yes, fantastic.
On the Hudson River, right? So if you're flying from New York to Ohio, where that plane was going, 99.9% of the time, the plane's going to get there safely or more, right? But if you had the bird strike, you want Sully as your pilot. So if I'm in Germany and I'm getting treated for prostate cancer, I want Alex and his team as my pilot and my co-pilot. It's regardless of the technology.
Yeah, absolutely. That's the most important factor. So your prediction for the future for prostate cancer treatment, I mean, apart from the biological and immunological studies which are going on, you think, probably you think, but is radiosurgery the #1 treatment application for like at least most lower intermediate grade prostate cancers?
I think it will, I think it will be one of the top treatments. Again, based on what we talked about, again, I will never talk a patient out of surgery. But I think it's as effective as surgery without you having to have surgery. So it checks good boxes that way.
Okay. Well, thank you, Jonathan. I think it was an interesting chat with you as, again, one of the world experts. I think we learned a lot what can be done, what are the capabilities of radiosurgery, of SBRT, of CyberKnife for prostate cancer. We also learned about the limitations. I want to thank you personally for all your efforts you do in this field for like 20 years. And it's very encouraging to see how well this has developed. And you are one of the main speakers in this area. And I love to hear that your symposium is going international, maybe in Asia. So your reputation will be even bigger in the near future.
Thank you.
And thank you for taking your time to talk to us today. And